Hello, my name's Mark Smith. I'm one of the intensive care consultants and I've got a specialist interest in acute kidney injury. So acute kidney injury affects about 20% of our acute hospital admissions and contributes to approximately 100,000 excess deaths in the UK per year, up to 30% of which are preventable with the right care. We're relaunching the acute kidney injury electronic care bundle, including the addition of a soft stop. So what that means is if a patient has had acute kidney injury in the preceding year or during this admission, it will prompt you when you're completing any orders for blood tests or chest x-rays, for example, to complete an AKI electronic care bundle. So I've got a patient here within the test system. So I've been prompted to complete an AKI care bundle. So I'd go to Document and New. I've got AKI bundle as one of my favorites. So you will see from the lab results normally that it will give you an AKI, a creatinine, and the staging and the potassium. So when it prompts you to do that, you would click here and it will bring all of those in. So in this patient, fictional example, the patient's got potassium of 2 and an AKI warning of 9, which obviously doesn't exist. But the staging will be between 1, 2, and 3, or 0. You would initial to say that you've seen these results, and we'll say that this patient has a stage 3 acute kidney injury. If the patient had had an AKI in the preceding year, but the AKI was resolved, you would click resolved, and that would mean that you don't have to fill out the rest of the form. But in this example, the patient has acute kidney injury, it's not resolved, and it's a stage 3. We then go on to the causes of acute kidney injury. I like the STOP acronym, which stands for sepsis and hypoperfusion, toxins, obstruction, and parenchymal kidney disease. The reason I favour that over pre-renal, renal, and post-renal is because it gets you to the most frequent causes straight away, which is sepsis and volume depletion. So in this example, we'll say the patient has AKI due to sepsis and hypovolemia. That there was some toxicity because the patient was on some non-steroidals, some diuretics, and some ACE inhibitors. That there was no obstruction, and that we didn't think that parenchymal kidney disease was part of it. The next step after identifying the cause would be your investigations. So urinalysis is something that we often do, but we're very poor at documenting. And the reason that's important is because the urinalysis is the bit which will point you towards whether it is parenchymal kidney disease. And in that example, it would be that you had gross proteinuria normally. So in this example, we will say that the patient has a normal urine dipstick, and we will document it here, and that the urinalysis was complete. The next step is to document your examination and resuscitation of the patient. So in this case, we will say that the patient is dehydrated with no palpable bladder. That the patient is hemodynamically stable after some resuscitation, and that the patient doesn't have hyperkalemia. If the patient does have hyperkalemia, there is a life-threatening hyperkalemia algorithm available on the hub. The next question is to remind you to ask the nurses to complete fluid balance monitoring on all patients with acute kidney injury. The only real exception for that would be if the patient is actually for end-of-life care. The next important step is the medication review. Again, there is a comprehensive guide to medications review on the Think Kidneys website, but these are the common medications that we should stop or reduce the dose of. So in this example, we're going to say that the patient was on some non-steroidals, ACE inhibitors and diuretics, and that we're actually going to stop these medications, but we're going to continue their aminoglycoside antibiotic because that was the main treatment for their sepsis. The next stage is if you need help, which would come in the form of a referral, and you will for some patients. Acute kidney injury stage 1, perhaps not if you know the cause and you've treated it, but for acute kidney injury stage 2 or 3, you will nearly always need to make a referral. That comes in the form of either a referral to my team, critical care, which would be for people with multi-organ failure, hemodynamic instability, or hyperkalemia refractory to treatment. The other teams that you can refer to are renal via switchboard to STH. And in this example, we will say that this patient has had an acute kidney injury and they also have a renal transplant. So renal would want to know about that. Urology would be for obstruction which isn't relieved by a catheter or pyelonephritis in the context of acute kidney injury. The next step is to request an order set. So that will request all of the relevant investigations, including the U&E for the following day. And then you can save the document. The importance of this document is, as well as documenting your treatment of the AKI, it will flow through to the discharge summary, which will inform the GP at discharge what medications you've stopped and allow you to give the GP advice on monitoring and when to restart medications. Thank you very much for watching the video.